All right, welcome to the AutoimmuneDoc podcast. As always, I'm your host, Dr. Taylor Crick, and today I'm here with my friend and colleague and somebody who I look up to a lot, Dr. Roberta Van Zant. So Dr. Van Zant is a DO in my local area, so that's kind of how we know each other. Her practice is about, 10 or 15 minutes away from me, and so, in our area of Central Illinois, there's not a ton of people doing, some version of what we do. Now, she also does general medicine as well. So we're going to ask her a little bit about what she does and some of her specialties. But she's a friend of mine and somebody that I have a tremendous amount of respect for. So we practice in the same area. And Dr. Van Zant, you're just very well known and well respected. And I think that both globally, like through iLads and some of the things Lyme wise, but also locally, everybody speaks very highly of you. So I'm really excited to have her on here today. So Dr. Van Zant, just say hi to everyone, please. And then I'm going to go on a little bit of a ramble before I start asking you questions. But how are you today?
I'm doing great. And I want to thank you for giving me this opportunity to talk today about this conversation of
Yeah.
infections because it's, I think, more important now than ever. And the patients that I've seen, it's become a topic of conversation for quite a few who are coming in with concerns as to what could be going on for them. So it's absolutely timely.
Yeah, and I think that Dr. Van Zandt and I have had other good conversations about, toxins and some of these other things. And I think that most people in the healing world, would say that things like chronic stress, poor gut health, infections, and toxins kind of cause disease processes. But I did want to talk to Dr. Van Zandt today about infections because I think that she has, expertise on infections that's beyond mine. And part of that is because of her experience, and just treating these things longer than I have, and also partially because of her scope, her scope of practice and with diagnosis and medications and things like that. And with me being a chiropractor, that's just not part of my background training as much. But there's a lot of different, infections that are out there. There's strep, there's mycoplasma, there's mold colonization. Dr. Van Zant knows very well that I'm a big mold guy, but there's also these viral infections, obviously COVID. The infections have really taken a front seat in the last 5 years, but there's Lyme and there's tick-borne infections, which is again, a specialty of yours, is Lyme and tick-borne infections. But I think that the point is there's all these different infections. There's all these different bad guys. How do we narrow in on the bad guys? How do we get rid of the bad guys? How much do these bad guys really, matter in the big picture as far as the individual ones? And those are some things that I have some questions on. So I've got some specific questions for Dr. Van Zant, but I also warned her that I'm going to go through just a little bit of a spiel on infections before I start asking her opinions. And some of this is me sharing my opinion. And I think that the appropriate word is really biases, but I don't want to be biased. So that's kind of my point of saying these things. And then I want you to correct me where I'm wrong or give me your opinions. I think that again, in practice, we develop these biases or these tendencies of things that we continue doing. And I'm not opposed to that, but I'm also always want to stay open-minded of, well, what else can help, the patient sitting in front of me. So here's my opinion on infections. First off, I think they matter. So we can start there. Obviously, I think they matter, but influenza A is ripping through my kid's school right now. So half the kids in the class will be out at once. So I think that the transmission of them, you can clearly see that in families or classrooms. I think that walking pneumonia is another hot topic. I think that bird flu, COVID, I think they matter quite a bit. I think that I don't know what you want to say, as a healer, as a practitioner, I personally lean away from infections. And I think that again, it's probably bias and scope limitations too. Not that they're not as important, it's just not something that I've been trained on or that I treat as much. So I'm happy to admit that, but I want to stay open-minded and not be blinded on them. So these are some of my comments on infections in general. So one, and I'm reading from my notes here because I was taking some notes about this, but one, I think that a lot of medical practitioners, MDs, DOs, medical practitioners are more well trained in infectious disease. So they're looking for infections, just more than me. And also you're better at looking at them and better at using things because you have to know the difference between antibiotics versus antivirals versus, when do I use penicillin and amoxicillin versus Keflex or, fill in the blank, for the different, medications and knowing when to use the right one, or antivirals, antifungals. So I think that you guys are better at treating at them, but that's kind of a philosophical thing. I think that testing, I've got some questions with regards to testing, meaning again, just not necessarily asking you, but just in general for me, a lot of infection testing is done through antibodies, and there's a lot of controversy with antibody testing, even when you understand it, of how long do antibodies last for, or is it an acute exposure? Is it a passive exposure? Meaning with regards to IgG versus IgM. And I know there's also, you know, PCR testing, and there's some more detailed tests for especially the Lyme and the tick-borne infections. But the testing is sometimes, to me, a little bit ambiguous of it doesn't always show us the whole picture. Then I think there's some other things that I just think about, like, well, what about biofilms and these like chronic pathogen burdens that can be in our sinuses or on our tonsils or adenoids or, in the urinary tract with UTIs or things like that. That's again in my head, it's just really hard to test for. There can be, there's CT scans, but, testing for biofilms in the adenoids, tonsils, sinuses, which again is something that I'm really big on because of my own personal experiences and just seeing a lot in the mold world too. And then I think, treatment from a natural standpoint, it meaning like what's available to me in the herbal supplement essential oil world, antimicrobials are kind of antimicrobials. So they're not that specific. Now, yeah, some, how to Arco might be better for fungal things and I don't know, like echinacea might be better for viral things or whatever. But in general, from an herbal essential oil standpoint, it's just antimicrobials help reduce the pathogen burden. So I take more of a global approach to it. And I've heard it said from a mentor of mine that there's all these different bad guys. But the goal for me and the way that I present it to patients or clients is our goal isn't to go after the individual bad guys. Our goal is to lower the crime rate of your city. And that might include the murderers and the rapists and the burglars and all the bad guys. But it's lowering the crime rate of your city just with pathogen burden. So that's what I want to talk through with you about, is just kind of how you approach these things if somebody comes into you with, and let's just cherry pick one, but like OCD. That's growing in the world of, PANS, PANDAS, and strep and stuff like that. But how do we know what infection we're looking for? So before I start getting into that or jumping ahead, Dr. Van Zant, tell me a little bit about, how you got into this. And I don't just mean infections, but meaning functional too, because I think that as a traditionally trained, doctor, a lot of times you don't start looking at mold, Lyme, heavy metal stuff. You start by just seeing sick people, and then you start asking why questions. But how'd you kind of get into a little more functional, integrative medicine?
Well, I actually had a bent for this early on. It's why I went to medical school. Of course, functional medicine wasn't a term that I knew of before I wanted to go into medical school, but holistic was. And I always knew I wanted to be a holistic doctor. And when I say
Well,
holistic, I mean,
that's cool because too, it's hard to jump in, but most people don't start that way. But yeah.
yeah. And so I knew that I wanted to treat the whole person. And that was very important to me. I wanted to take that global look. And so of course, functional medicine fits right hand in hand with that idea of trying to understand globally what's going on with a person. And so that was really my whole purpose for becoming a physician. Now, along the way, I did go, even though I was an osteopathic physician, DOs have pretty traditional type training. We take the same types of classes. We do have extra training in osteopathic manipulation, so that's some additional tools we have. And there is a little bit more of, I would say, a broad emphasis on understanding things globally, but I still would say that I was trained rather traditionally, including in my residency program. And, the traditional approach, for the lack of a better word, is really a cookbook approach. You're trying to drive a patient to a diagnosis in a short period of time by asking specific questions that's going to get you the diagnosis code so you can give them a treatment and move on. That's how our healthcare system is set up. And so that's very much how I was trained. And I appreciate that approach actually, because that approach is very pathology based. Really, we have to learn all the bad stuff, right? We have to learn the worst of the worst. And I appreciate having that training, that approach, because it helps me as I'm assessing somebody kind of click through the things that what's the worst possible thing that could be going on for this person, and making sure that that has been evaluated or will be looked at, as far as what I'm considering. Because normally when people come to me, I'm not the first person they see.
Right.
Not always. I mean, but oftentimes they've already seen other providers in the traditional world and haven't gotten the answers or the complete set of answers. So, you know, traditional training has served me well to give me that great foundation. And then after I got out of residency and started working with patients, it's really when functional medicine, I guess, as a term came around. And I actually did a women's health fellowship. And so some of the very first things I ever implemented were hormone therapy, understanding the HPA axis, the hypothalamic, pituitary adrenal axis, understanding thyroid dysfunction. So that was kind of my core functional medicine training. And then, you just add on over the years, add on the additional things that you need to learn. So training for me to treat infection was my end stage. That was the last thing I added on. And it wasn't because I had this great passion about it. It was really just what I was seeing and who was coming to the door. And I really feel like over the years, it's become much, much more complicated. The patients who come to me now are way more complicated than they used to be.
Mm.
Because when I first started, you would guide a patient through an elimination diet. You had to tell people what gluten was. Those are the days of the past.
Mm.
Nobody really needs to be educated in that anymore. Most people understand that or have done that or have seen a nutritionist, a dietitian, a chiropractor, or maybe another physician, even who has advised them to try some of these dietary modifications. And so those days where we're just working solely on what are you eating, what could be bothering you that you're eating, I feel like that's the simple stuff now.
Mm.
And
Yeah.
and now when people are coming to us, they're ill. They're very sick for the most part. And so infections are always the forefront of my mind to try and figure out if that might cause. And so really it's been a journey for sure that's brought me here.
Yeah, well, and I think that just to backtrack, like, you see people and let's say you put 10 people on an elimination diet and six of them get well and four of them don't. And then you think, well, why? And then you think, well, it's their thyroid or it's their adrenals. And you start uncovering that. And then 60% of those people get better. And you think, well, why? And as you just keep going upstream, in functional medicine is a term that I kind of vibe with and is a more, I don't know, more modern term is just is again, it's not always been that popular, but I think that it's always this root cause medicine or root cause,
Right.
wellness and going upstream. And it
Right.
just doesn't get much more upstream than infection burden or toxic exposure or some of those things. And a lot of times we see these sick people and they've got both, it's not one or the other, but they've got a little bit of both. But that's kind of how your practice has evolved. So talk to me about infections. Now, again, broad question, talk to me about infections, but I just mean in general, like what role do you feel like they play in symptomatology and autoimmunity? And let me set the stage a little bit easier because everybody gets sick, right? But not everybody gets chronic long-term symptomatology. So is that something, is it like death by a thousand cuts? Or is there, one straw that sometimes breaks the camel's back? Or is it a combo of things, do you feel like? Because again, we could have viral infections, we could have bacterial infections, we could have fungal infections. Um, and some people don't have any lingering effects from that. They just get what I would call normal sick. So talk to us about infections and the role they play in, I don't know, inflammatory autoimmune conditions, I guess.
Well, with the name of your podcast, being autoimmune, I think that you you can't not talk about the autoimmune reaction when you're talking about infections because they go hand in hand. And of course, in traditional medicine, autoimmune disease is largely thought of as something where you have a label to it. Oh, do you have lupus or do you have connective tissue disorder or you have a non-specific connective tissue disease that might turn into something. But to me, I mean, the immune system is so intricately connected to everything that our body does that, it's handling what we're dealing with every single day. We deal with infections every single day in our body. We deal with cancer cells every day in our body, and for the most part, people troop along and never even know about these types of things that are going on in their body. But yet, the immune system is reacting, and it's the reaction that really can trigger these autoimmune responses where it gets confused. And the question is, why is the body getting confused and attacking itself? Autoimmune issues. So, infections that cause problems for people are really causing autoimmune reactions for the most part, whether that be something going on in the gut with bacterial imbalance and a bacterial infection, or whether it's Lyme disease or COVID or viral infection. There's a great immunologist, I know Dr. Vajdani, and I
Oh
just
yeah.
appreciate Dr. Vajdani from Cyrix so much because, he explained this concept of our immune system attacking something that's in our tissue. And as it's attacking the tissue, it's not, or attacking the pathogen in the tissue, it's not just attacking the pathogen, it becomes a pathogen tissue attack. And so you can actually then develop an attack of the tissue while you're attacking the bacteria or the virus. And how the immune system is so beautiful, but it's also gets confused. And so that is difficult to unhook. And that's really what we, label as an autoimmune disorder, is this confusion of the immune system. When it's attacking infection, it's also starting to attack tissue. So there can be that conjoined attack, or it can be a molecular mimicry, which is whatever is going on that the immune system is attacking. Well, that looks an awful lot like part of our body, i.e. that's pandas, where our body starts to attack the dopamine receptors in our brain when it's really meaning to attack the strep molecule, the strep
Hmm.
bacteria, because there's such a homology in that genetic basis of what it looks like. And so, our immune system's trying to do the right thing, but it's just off by a hair, right? And so then people suffer significantly. So why does that happen? Well, I imagine there's a lot to that question and answer, but I think when you break it down, it's immune incompetence. There's something that's made the immune system more overreactive. Is that environmental? Is that toxins? Toxins being a pretty big term, mold toxins, outside toxins from petroleum or plastics, etc. Is it that's making our immune system inappropriately overreactive? Or is it something that's triggering our immune system to actually be kind of under functioning in one sense, right? Like an arm of the immune system is not working like it's supposed to keep things in check. And so then you have kind of two wars going on. You've got
Yeah.
like what's living at home, and then what's trying to come in, the intruder. And so, the immune system is not able to handle everything.
Yeah, and you're
It,
describing the way that I'm picturing it in my head exactly because
yeah.
we've got on one hand this overreaction
Mm.
where there's inflammatory response and the immune system's like attack, attack, attack. But at the same time, there could sometimes be this underreaction, and it just basically leads to immune incompetence
Yes.
where we've got this inflammatory response, but we've also got this growing pathogen burden where these viruses or bacteria might be replicating or growing kind of in the background. And it's not necessarily like a flu that you picked up from a classmate, but
Right.
you've got this growing burden, whether it be in the gut or some of those other places that you mentioned. But yeah, it's all those things can all be happening kind of at once, which again makes it hard to navigate, hard to test for things like that. So I completely agree.
So when I talk with patients who I've diagnosed with some sort of infection that I feel has been there for some time, and is causing their problems, I'm we talk about, what the treatment strategy is, people want to know, can I get over it? Am I going to be, will I have chronic Lyme, or am I going to be sick for the rest of my life? And, my best answer is our goal is to get rid of as much infection as we can to allow your immune system to handle the rest and allow your immune system to become competent again to do what it's supposed to do.
Yeah.
And along the way, we're going to try and help to rebalance things. But it's like, you're in a war that you're losing, and we need to help you win. We need to help your body win.
Yeah. But a
That's
lot of
very
people think
simplistic,
too, sorry.
but I think it's important that people understand that, we're not clean inside of us. We have lots of stuff that lives in us all the time. In fact, you know, I I read a very interesting article the other day about a researcher who's actually studying the biome of the brain in fish and finding that fish brains actually have their own bacteria. And I thought, well, wait till we find out, that our bacteria, that we have bacteria in our brain. I mean, who knows? Like, we are not sterile beings. And I think it's important that we understand that this is something our body navigates all the time, like maintaining health amid a lot of other things that are hopefully symbiotic, like helping us. But
Yeah.
it's the ones that we don't want that are creating that extra inflammatory response that we need to try and figure out, how do we stop that process going on and help our immune system to get back on top?
Yeah. And I like what you said about it's not, we're not sterile.
Right.
But we've got this too much burden that the body can't tolerate, or it's just, it's too much. So our goal is to reduce the pathogen burden, let's say, just so your immune system can pick back up and do what it's supposed to do. So
Right.
we're not trying to kill off every bug, or I say the same thing about toxins. We don't sell plastic bubbles. We're never going to be toxin free. We're never going to be pathogen free. But do you have too much burden
Mhm.
that your immune system is not doing what it's supposed to do? And that's most of the people with, some degree of symptomatology. They've
Right.
got some chronic pain, they've got some chronic neuro thing, they've got some chronic histamine response. So that's a lot of people that maybe come into our offices. What about, you touched on this a little bit, but again, I think that a lot of this is semantics too, because, and we've all been trained to think like, oh, this is strep. So then what's the bad guy in that story? It's strep, so we want to go after that like it's, Osama bin Laden, but the war is bigger than just one bad person, I would say. Or right now it's COVID. But what is the difference between acute infections, meaning something that your coworker had and then you have, right? We all know what that is, a caught a sickness, versus chronic infections. And also too, Dr. Van Zant, the same question, but like you said it too, but we've got, 10 pounds of bacteria in our gut. So we've got strep in our gut,
Right.
but that doesn't mean we have a strep infection. So again, that's a little bit of semantics, but how do we rule that out with these imbalances or colonization versus when do we call it an infection, just from a terminology standpoint? And also too, part of that again, but like viruses, we've got viruses that we can catch like COVID. And then in theory, it's gone. Now, obviously, we've got this viral persistence and things like that. But we've got these other viruses, like let's say a cold sore, that sometimes can be dormant for years, decades. But then you get stressed, you get, some kind of other, immunological insult, and then all of a sudden that thing wakes back up again, and you get a herpes outbreak. So how do we differentiate acute versus chronic infections and some of those things, or help people maybe understand that a little bit more, I guess?
Sure. Some of this has to be about the strain of whatever virus or bacteria you're dealing with. There are strains of viruses that are seasonal, that are short-lived, that are relatively innocuous, and that they may come in with a bang, but um, they are not meant to live in our body chronically. It's just a short firework display, right? And then they're
Okay.
gone. And um, those viruses are not persisters in our body. We know that there are a few viruses that once they enter our body, they can and very likely do persist and will have them forever. Things like Epstein-Barr, cytomegalovirus, varicella.
Chicken pox, yeah.
Yeah, yeah, herpes virus, yeah, chicken pox. something called HHV6, which causes roseola in little kids. Those viruses stay in our body. We know that varicella, chickenpox, lives in the nerves and can reactivate in nerves. So they all have their little places that they can stay. And that's normal, completely normal, versus your cold virus that comes along. And that's never going to stay in our body chronically. It's not where it normally lives. So, there's several viruses that we know are chronic pathogens in the body and can get reactivated in the right situations, the ones I just listed. COVID is not considered a chronic virus in the body. That's been well documented. It doesn't mean that you can't have particles left over from COVID that could potentially be encapsulated in white blood cells, but the whole virus doesn't live in the body, nor does the flu virus. It doesn't stay in the body forever. I mean, these things are passing. It's like a ship that passes in the night. Those viruses that you hear the most about, Epstein-Barr, et cetera, those are the ones that we need to be concerned about because that's where all the research has been done. We know that, Epstein-Barr has been linked to Guillain-Barré. It's been linked to chronic fatigue syndrome. I mean,
MS, yeah.
MNS. I mean, there's tons of things that we know that Epstein-Barr virus has been linked to as far as activating or contributing to the disease process, but most things don't last. Same thing with bacteria, although bacteria is a little bit different because
Hmm.
bacteria, there are bacteria that can actually create biofilms. And biofilms, as you know, are those, I just like to call them those little hotels that get erected and they're the safe spot, right? They're the safe house for those bacteria to go and hide in and replicate and invite all their friends and neighbors, the other viruses and fungal organisms. Everybody gets in there and parties without the immune system or whatever we're treating the problem with, the antimicrobials, the antibiotics, to be able to get to them. And there are bacteria we know actually can create those biofilms. Some of them are ones that are pretty common to people, things that cause sinus infections. Some of those can create biofilms. Things that cause joint infections can create biofilms in joints. These are well known in the traditional medical world, but the treatment for them has just been, well, we give antibiotics for a long term to hopefully completely eradicate as much of the infection as possible, but you're not addressing the biofilm. Tick-borne infections, we know that tick-borne infections, Bartonella and Borrelia in particular, those are biofilm formers. And so things that form biofilm are a whole different beast because those are the ones where they can exist in a person's body, and the where and why they start reacting, that's a little more complicated. We know some of the details behind that, like immunosuppression, obviously can lead to a reactivation of infection or significant stress. I mean, biofilms have stress receptors. So under a huge time of stress, that biofilm can get basically activated. It's like, they're told the house is on fire. So all the organisms start leaving the biofilm and we see active infection come from stress. But that's probably also a little bit simplistic, but we know that, biofilm and bacterial biofilm is a source for those longer or recurrent or difficult to identify and treat infections. And it's the party, right, that goes on, the multiple different organisms that can live in the biofilms that make it more difficult for us to absolutely, without a doubt, say that symptoms are because of this or that.
Yeah.
Rather, we're looking for what's triggering the immune system the most actively to identify what to go after. And that's usually by those antibody tests, right?
Okay.
What does the immune system seem to be triggering the most aggressively right now?
Yeah, because even
And
with
let's go
regards to
after that.
gluten or so, the elimination at or food sensitivities, that's the same thing we're looking at. If somebody does
Right.
a food sensitivity test, what is the immune system attacking the most aggressively?
Right.
Um, but yeah, that party, I like that saying it's the party. And so going back to the biofilms too, biofilms in the adenoids are associated with recurrent ear infections and things like that with, some of the things that we see commonly in childhood. But that can also, so recurrent ear infections can also be, there can be strep at that party. There could be staph at that party. There could be Pseudomonas or other bugs, but the party is causing the inflammation that can present as brain things in pandas or ear infections in ENT issues, but it might be the same party. And it's sometimes hard to get the exact guest list of who all's at the party,
Yeah.
but we can kind of see through the patient's, presentation. Is that party being thrown every weekend? Or is that party just I get once a year, I get a sinus infection or an ear infection or something like that? So I like that metaphor. What about, I don't, again, a broad question, but what about tick-borne infections? Because I do think that there's still some confusion with the semantics of, viruses and bacteria and strep, but people have a better understanding of like colds and flus and strep throats than they have of Lyme and tick-borne infections. So tell me about tick-borne infections, because some of the, again, things, even to me clinically, I'm like, man, well, how do we test that? How do we treat that? How do we know? But like Lyme can be passed in utero. So it's not that you necessarily got bit by a tick, but that your mom could pass that. So how do we talk about that, but also going into how do we differentiate between this? And are you a person that just tests for all infections, or as you're making, your kind of differential diagnosis list, are you kind of ruling some things in and ruling some things out to say, here's what I think we should test for. Let's test for these tick-borne infections, let's test for these co-infections, or if somebody's got, swollen lymph nodes, maybe you're going to be testing for Epstein-Barr virus. But talk about tick-borne infections, and then I'm going to segue into the testing. So handle that in whatever order you want, Dr. Van Zant. But the Lyme and tick-borne infections is, again, something that you have a lot of expertise on. Now, I'll also say, I do Western blots and things like that, but there's some limitations to even those tests. But there are some better tests, some more advanced testing when we get into some of the more Lyme and tick-borne infections. But how do those differentiate from strep throat or influenza or colds or things like that?
Well, I'll tell you, when I first started treating tick-borne infections, you just learn along the way.
Yeah.
And when I first started treating it, I learned that certain infections had certain presentations or more were more likely to cause symptoms. For example, joint pain, think Lyme disease, night sweats, think Babesia, lymph node swelling, think Bartonella, So I used to actually not necessarily test if people could not afford the testing.
That's another
I
concern.
would
Yeah.
treat more based on symptoms and exposure. What was their history? Do they spend a lot of time in the woods? Do they like to camp every summer up in Wisconsin? Trying to trying to understand what the risk was based on what their symptoms are. And the symptoms, I would have to say, largely drive when I think about infection, because the symptoms are chronic, persistent issues that don't make sense
Uh-huh.
in people. I mean, it's that simple.
Yeah.
When a college age person comes to me and they've had to drop out of college because they have new onset seizure-like activity and are so tired they can't stay awake, that's an unusual thing. They used to be a track star, now they're not. 100% I'm thinking
Yeah. That's not the
infection,
stress
you
of their
know?
school load. It's something else.
Right. I'm not thinking maybe they have acquired an autoimmune disease. I'm like, what happened to this person that their life has drastically changed? Or a 40-year-old man who, we've checked all of the hormones, things look fine, but they're tired and they have a lot of joint pain and they just don't have they try and take care of themselves. Maybe their wife tries to cook pretty decently for them and they don't feel good. I'm thinking, what chronic infectious burden might you be dealing with that is dragging you down?
Mm.
Because the immune system handles about every day, the immune system works at about 50%. Like it's just surveilling, like what I said earlier, trying to prevent you from getting sick, trying to prevent you from getting cancer. Like it's working every day. It's never just quiet. So when you have an active infection on top of that that is not being eradicated, that drains the energy resources, right? That creates that brain fog and fatigue. You just don't feel good. So I'm looking at infections where it makes sense that people don't feel good despite what we know about them and what's been checked. And when I'm checking now, I just go for the gold because people aren't there for the most, they want to know what's wrong with them. And
Yep.
so I am not limiting my testing unless it's truly financially limiting for them. But the nice part is, at least at our office, we get a lot of things covered by insurance, including some of the um, um, higher tier testing. IGeneX, which I know you know about, is kind of the premier tick-borne test, and it's because they've invested tons of research, data, money into making sure that they have a test that's reliable. And
Hmm.
so when I check for tick-borne infections, I do everything I can to get a person to get a comprehensive panel through IGeneX that checks for all the known tick-borne infections because we have them all here. We have they're
Right.
almost all over the United States. People travel, ticks travel, birds drop them, from the East Coast, from Michigan down here. So we can't assume just because somebody hasn't traveled somewhere that they may not have one of these infections. So I'd rather be
Right.
safe than sorry.
Yeah.
I'd rather know the whole picture. And so for me, I test for all of the tick-borne infections. That would be Lyme, tick-borne relapsing fever, which looks a lot like Lyme, Babesia, Bartonella, Rickettsia, Anaplasma, Ehrlichia. And if a person is really sick and I'm just trying to figure out if it's viral or bacterial, we'll check a whole viral panel where, we're looking for those viruses that can be reactivated. We'll look for Mycoplasma, Chlamydia pneumoniae, Toxoplasma, Strep. We check for anything and everything we can that we think could be a pathogen in this person because
Hmm.
you never know what you're going to find. You never
Yeah.
know what is going to be the underlying issue. And I'd rather know more than less. I want to confidently say what I'm treating, not guess or scratch my head and wonder if I'm missing something. I'd rather know going forward. And IGeneX testing is really highly validated. In fact, and you probably know this, but the Immunoblot IgG test was approved by the FDA recently, which means that now they can market it to all the hospitals. So instead of having the substandard Western blot testing at all of the different labs, potentially you could get a highly accurate IGeneX recombinant immunoblot that has almost 100% sensitivity and specificity. So when you're getting Western blot testing done for Lyme disease at Quest or LabCorp or OSF or any of the labs that may be at, in a person's area at a hospital system, they pretty much all use the same or very similar box kit for an ELISA test and then second tier Western blot test. And it's been shown that those tests are only about 40 to 60% accurate. And there's actually a high false positive rate based on potential viruses or things that might be
Cross
cross-reacting to
reaction. Yeah,
antibodies.
exactly.
And so, I want to treat uh, on the data and we can get accurate data. And
Yeah.
so for me, IGeneX testing for tick-borne infections is a standard and I check
Yeah.
for everything I can. And we'll do what we can do if we need to check something called fluorescent immunostaining, PCR testing. I mean, if IGeneX has panels, and so we try and incorporate as much as we possibly can to get a positive test because although their antibody testing is accurate, sometimes we get negative antibody testing and a positive fish test, which is more accurate because it's an actual bacteria that they found. So
Mm.
as much as we can do to figure out what to treat is better for that person in the long run. It means
Yeah.
we're
Yeah.
more specific. The treatment hopefully is going to be more specific and maybe shorter because we're not making as much guesswork.
So then let's say you do, the whole 9 yards of testing on somebody and they have a tick-borne infection. Let's say Borrelia, which is Lyme, and just for simplicity. And then they also have some viral things. They have Epstein-Barr virus, and then they also have staph or strep. And so then where do you begin? Now, again, obviously that's customized, and we're not asking for clinical advice on the podcast here, but the point is like they've got all three of these bad guys. Do you prioritize? Do you pick and choose, with regards to the gut or the treatment options available? How do you put that into, your clinical framework? Because I think, and I'd be curious to hear your opinion too of like how often do you just find like one bad guy? It's
Yeah.
probably, in my opinion, not that often. It's probably you more find this poly infectious state or this multi-systemic infectious disease, this MSIDS type of presentation like Richard Horowitz talks about. But it's like multiple bugs in that crime rate of the city. So how does that fit into a clinical framework?
Yeah. Well,
Hmm.
I do think that they call ticks nature's dirty needles for a
Mm.
reason. And so, and especially if people have been bitten by multiple ticks or exposed multiple times, you don't know what they picked up when. And so, yeah, we need to make sure that we're identifying everything and we can treat effectively. But generally, I would have to say tick-borne infections come first because
They're your, yeah.
they're the top priority when
Because
I'm
they might
looking
be
at things.
why, and I don't
Yeah.
know, but they might be
Well,
why the
because
virus is
bacteria are
reactivating
pretty
it.
easily killed, right? I mean,
Yeah,
bacteria, we have tools for it, and I can see if a person is going to get better by treating bacteria more quickly than by treating viruses
good
for the
point.
most part. And if you get the immune system back online quicker by getting rid of these chronic bacterial infections, then it may be able to push that virus
E-
back in its shell a lot easier
Exactly.
on its own.
Because I think the
So,
question is if they're reactivating, if we all have them, the question is, well, why are they reactivating? And so you get the immune system in check, then they go back dormant or whatever
yeah,
it is. And yeah,
yeah. And for lack of a better description, I always say it's like a parfait. You just start at the top and you start taking the layers off and you
yeah,
hit the low hanging fruit. You get the bacteria, you start scraping that off with the easiest to kill things, antibiotics potentially, and slowly as you see people getting better on that uphill climb, you're looking at the things that are left, the things that may or may not be bacterial related, the
yeah,
things, we're trying to figure it out till you finally get down to scraping off the bottom of the bowl, which is the biofilm. And so, people come in and want to go, well, shouldn't I be treating biofilm right now? And I'm like, heck no, you don't want to start blowing up the place. You won't tolerate it well.
yeah.
So
That's a
we
good
have a
call.
very targeted approach, which is starting at the top and working down. And
And
you
let
had
me
said,
ask you this while you're talking about it too. Sorry to jump in, but because, and this is probably my last question, just to respect your time, but you also have in your toolbox pharmaceuticals, like you're mentioning, and I would call them the big guns. Whereas to me, I'm just vitamins, herbs, tinctures, things like that. And you use an integrative approach, and I think that I might have just answered my own question to you of how do you do this? It's like, well, we do it both, and we pick the low hanging fruit and stuff like that. But you take this integrative approach, and you kind of put them in stepwise fashion. You're not
yeah,
trying to go, take the machine gun approach of let's see what we can hit. It's more like let's do this first and some of the easier start at the top and work down.
yeah,
But that's kind of how you the treatment tools as well. Um, so yeah,
yeah, yeah. I would say there's not, a consistent approach with every patient. I don't
there
always
can't
use
be. Yeah,
antibiotics. I don't always use herbals. I try and make sure my patients are educated, and it's a lot of information, but if people, I would say 80% of people come in and they know somebody that has had Lyme or they've read about it. Or there's very few people who come in and don't have any clue about infection and how we might want to treat it.
uh,
Um, yeah, I mean, people are very well educated. They have the world at their fingertips now with Google. And when people aren't feeling well, most people are on the internet trying to figure out what is going on with them because they're not getting answers. And so, for better or for worse, they come in armed with a lot of information, but it does make, I feel like, my job somewhat easier as we talk about options. Um, and the options are really based on, what I think the person would get better more quickly with, how badly they're doing, what kind of diagnostic information can we use from treatment? Like if I think that, we could use 2 months of antibiotics and see a 50% improvement in their symptoms, and otherwise, they don't have a lot of gut issues going on. They don't chronically already have abdominal problems or diarrhea, then I feel like sometimes that's the best answer to start. But some people don't want to do that at all, which I respect. And herbal antimicrobials are amazing. There's I don't know how many companies out there now that are targeting tick-borne infections or other, infections, strep, etc. And we use them quite effectively. They generally tend to be well tolerated, don't have the same hit on, the gut. But, the downside is they may not quite do the job for everybody when you start. And so you have to have that discussion and really see what resounds with that patient. Some people have very strong opinions, and other people really rely on, the expertise of the years of experience that we've had and what we've seen. And so there's a lot of discussion that happens.
Yeah.
And I think
And
it's
it,
important that people understand that, this isn't a quick fix. Like, this is going to be a journey. And, I explain the whole um hypothesis of, like, cleaning up layers at a time, looking for improvement, and we're going to get there, but it's about regaining that immune competence. So
well,
I think that's really important for people to have feedback in, and to grasp that this is something where we're going to try and figure things out for them as we go, as they respond. And the infections, we try our best based on the data to in their symptoms to determine what we treat in what order. But I just want to comment on your the staph and the strep question too, because for me, strep is something that really causes very specific symptoms in my experience. Like, it's a very psychologically impactful.
because of the
And
dopamine and pandas, you mean?
yeah, and
Yeah.
so when people show strep, it's a very specific type of strep. That's the strep that causes strep throat. It's not the strep that lives on our skin. It's not the staph that lives on our skin. So those kind of, and we do have strep in our gut, in our intestinal microbiome, but that's not the strep that causes strep throat. So I mean, I feel like sometimes we have to be really careful when we say, oh, strep or whatever, because there's bad types of strep out there, and then there's strep that's normal. So very rarely are we treating the stuff that, is on our skin, the colonized on our skin. We're treating the strains that are causing disease.
Yeah, yeah. Well, and I think staph, I only bring up staph because the Marcons world, in the mold world, people get hung up on staph. But I'm like, hey, in these biofilms, there can
Yeah,
be other bugs too, and
absolutely.
Pseudomonas or Acinetobacter, fill in the blank with other things.
Yes.
But just because a Marcon's test comes back negative doesn't mean that people don't have any
Something going on.
colonization. So,
Yeah.
and I think that just to kind of wrap up too, I think that you approach things differently than me. Every practitioner does to some degree, but it's really the big picture is the same. It really starts with education of like, well, we have to know what we're aiming at, and you have to understand, from a patient perspective, you have to understand that this is a marathon and not a sprint, and we don't know everything, but here's what we know, and here's what we're targeting, and here's what we're looking for, and then start applying some things, and then following up and seeing, is it working? Is it not working? Are they getting better? Are they getting worse? And then putting a new plan in place. And that's kind of the treatment, strategy for everybody. But we've got different tools that we use. We've got different testing that we use, but it's still, are we seeing this improvement or are we not? And then making some deductions from that. Well, this doesn't seem like it's working, or this does seem like it's working, and starting with the low hanging fruit first. And I don't know, a lot of that stuff that we talked about. And again, we covered this pretty quickly, but it was great. These are all gems for people, whether they're trying to solve their own health journey or they're a practitioner. So I think it was really, really helpful for people. I don't
No,
really have much else to say, Dr. Van Zandt. I would just say, in closing, if there's anything else that you have to say, but otherwise, thanks for coming on. I know you've got a patient to get to here today. But the other thing I was going to say, I guess, and again, just big picture, but you and I being around here, we see a lot of people that have been exposed to toxins their whole life, the pesticides and farmers and things like that. We see a lot of people that have been exposed to infections their whole life. They're camping in the woods, they're milking cows. But we also see people that, from a religious perspective or whatever philosophical, they don't want to be on meds. They want to be on as little as possible or zero if possible. So we're trying to work around that. But that was just something that popped into my head. But anything else that you'd like to add in closing, and then we'll let you go
yeah,
here.
I do actually. I feel like it would be an injustice to not speak a little bit about the impact of COVID, because COVID
Oh,
has changed the landscape, the immune landscape. And when we're talking about chronic infections, COVID's created such a maelstrom that it's a common part of my, questioning and discussions with every patient, because we know that the COVID infection the literature is very clear that the COVID acute infection causes pretty significant immunosuppression, similar to that of somebody who has HIV. And that is where we really see these viral reactivations with people that are so different than anything else they might have experienced before. We're seeing, a weird shingles kind of reactions that don't look like typical shingles. And the reactivations of Epstein-Barr, et cetera, after people have COVID. But the flip side of that is even after their immune system might have kind of come back on board from the acute infection, the persistent inflammation that we're seeing from the spike protein of that virus being encapsulated by monocytes and causing persistent ongoing inflammation in people, the long COVID, it's dramatic. And there are so many tools to be able to try and figure that out for people. But that in of itself is causing viral reactivations and
100%.
causing people to have reactivation of these tick-borne infections that they never struggled with before.
Yeah.
And so I feel like COVID's really changed the landscape of infection and autoimmunity. And going forth, at least in this decade, it's going to be an active conversation for us to have with every patient when they're ill is how did COVID, a vaccination, et cetera, trigger your immune system to be inappropriately functioning in your body and allowing these infections to kind of take front and center stage. And so uh, that, and I also wanted to mention, genomics play a huge part in how people
Mm,
react. And
yeah.
I think, that's another thing that we always have to give consideration to. And we can check some genes to understand why people have more pain or more mast cell issues or more headaches or whatever, more gut issues. But the genomic impact on why people get sick is
Yeah.
something that's going to really dramatically drive, how we treat people too in
And
the
and
next,
you've shown me
10 to
before
20
some of the
years.
tools you use genomic testing wise. And I would also just chime in, of course I'm the toxin guy, so I'm like, and the environment, because a lot of the long
Absolutely.
COVID people that I've seen,
Oh,
it's
yeah.
like, oh, and I had mold 5 years before that and all these
Yep.
things. But it's all, I think the point is it's all these things. And I think we both agree it's infections, it's stress, it's immune suppression with some of the, IgG subclassing and some of those things. That's fascinating. And that's a great gem for you to drop right at the end there too, because it's so, so, so true. We saw HOTS and pandas type of things, before COVID, but it's like boom, just blown up with some of these, mystery cases, let's say.
Yeah.
Um, so yeah. So anyway, we'll let you get to your next patient. Thank you so much for being on here.
Yeah.
I'm sure
Thank
we could
you.
talk again with some of these things, even the
Love to.
genomic stuff. I'm like, man, I want to jump into that, but we'll let you go. But thank you, Dr. Van Zant, and great to see you. And I'm sure we'll touch base
Good to
soon.
see you.
And I'll send you a link and everything when this is released and everything like that.
All right. Great.